Assalamu alaikum. I am Dr. Safdar Sial. Today we will be discussing a very important topic in urology, that is how to proceed a case with renal mass. When you come across a case of renal mass, ask yourself 4 questions and try to decide about these 4 questions. Whether the mass is cystic or solid, whether it is expansile or it is infiltrative. Expansile means that the mass is coming outside of the kidney, and infiltrative, the mass is there but it is infiltrating inside the kidney. It's not coming like a ball outside of the kidney. Whether the mass is fatty or soft tissue, whether the mass is solitary or it consists of multiple masses. So tumor, when we talk of when we want to decide whether it's expansile or infiltrative, expansile masses which come outside of the kidney like a ball, these are spherical, these are exophytic, frequently these are encapsulated, these are malignant masses. It may be adenocarcinoma, metastatic mass or lymphoma, or it may consist of a benign mass like cyst, angiomyolipoma, oncocytoma. When the mass is infiltrative, the mass is there but it's not coming outside like a ball or extension from the kidney, rather it is infiltrating inside the kidney, infiltration, bean-like infiltration as it is called. It invades the parenchyma, preserves renal contour, is a poorly marginated. The expansile masses are usually encapsulated. These are poorly marginated. These may be malignant, most commonly the transitional cell carcinoma of the kidney, or squamous cell carcinoma, lymphoma, or atypical adenocarcinoma, or it may be a benign mass like pyelonephritis, tuberculosis, xanthogrammatus pyelonephritis. Etiology: smoking, hypertension, obesity, exposure to asbestos and tanning products, or it may be inherited when there is mutation at chromosome number 3 and 8. Pathogenesis: renal cell carcinoma originates, is the most common, renal cell carcinoma is the most common cause of renal mass. RCC originates from proximal renal tubular epithelium. Types is clear cell, granular cell, mixed cell, or it may be a sarcomatoid. Clinical findings: gross hematuria, flank pain, palpable mass are triad of symptoms. These gross hematuria, flank pain, and palpable mass, these triad of symptoms present only 10 to 15% of cases. Patient may present with constitutional symptoms like cough, headache, or bone pain. Clinical findings: paraneoplastic syndromes like erythrocytosis. Patient may present with erythrocytosis, hypercalcemia, hypertension, or hepatic dysfunction. Diagnostic: ultrasonography differentiates cystic versus solid masses. RCC can be hypoechoic, isoechoic, or hyperechoic. Hypoechoic, like this one, its echo density is less than the kidney. This is called hypoechoic. Isoechoic, if the echo density of the mass is similar to the kidney, and hyperechoic when it is echo density is more than the kidney. Here it is isoechoic. There is a mass, but it's the echo density is same like the kidney. Hyperechoic when it is more echogenic than the kidney. The different diagnostic modalities: intravenous urinography, only good for expansile masses, misses 1/3 of lesions less than 3 cm. Its accuracy is 75%. All lesions require further workup like ultrasonography, CT and MRI. So IBU or intravenous urography per se alone is not sufficient for diagnosis and staging of the renal tumor. The mass is, this is on renal IBU, there's a mass in the upper port. It will look like this. Diagnostic modalities, next is CT scan. This is the investigation of choice. 94% sensitivity for lesions less than 3 centimeter. 90 to 95% accuracy in staging. Can take pre and post contrast films of the lesion. Scan in both nephrographic and excretory phase. So first the films without contrast is taken, then the contrast is given and another film is taken. MRI, no added advantage than CT except in vascular lesions. So if you are suspecting vascular lesion, then MRI can give an added information. On CT scan, this is a CT scan of the abdomen. This is the left kidney and this is the right kidney, and this is a expansile or exophytic mass originating from the kidney. This is called exophytic or expansile like growth. If there is a growth here but it's not coming out like ball like this one, then it's a infiltrated growth. Renal aspiration, cytology, biopsy, indication metastatic disease, ill-defined diagnosis, metastasis in the kidney, radiological indeterminate lesions. So sometimes there is a mass, there is a primary somewhere else, and you are suspecting a metastatic lesion in the kidney. So you will like to do a biopsy or renal aspiration cytology. If the lesion is ill-defined, you are not sure about the lesion, that whether it's a benign or it's a malignant or it's an infective, so you do the biopsy or aspiration cytology. Metastasis I have already talked about. Radiologically indeterminate lesions. Sometimes most of the time radiologist tells us that whether it's a renal mass looks malignant or benign, but sometimes it's indeterminate and one has to do renal aspiration cytology or biopsy. Usually this is indicated in smaller lesions. Staging of RCC, objective to standardize the treatment. There are two staging systems. The latest one is TNM, tumor nodes and metastasis, and Robson staging system. This is still being practiced in some units, particularly in North America. So about the Robson, stage 1, it's confined to the kidney. This is stage 1. This is the lesion white. This is the lesion and it's confined to the kidney within Girota's fascia. So the tumor has come outside the kidney, but it's still limited to the Girota's fascia. 3A, renal vein or IVC invasion. This is 3A. This is a tumor and it permeates into IVC, renal vein and IVC. Lymph nodes, 3B. This is a tumor and the local lymph nodes are enlarged. 3C, vascular involvement plus nodes. So this is a lesion, it's a vascular involvement, the tumor permeates into IVC and the local lymph nodes are also involved. So stage 4A, direct organ invasion. Like this is tumor and it has come out and it has invaded the contiguous organs. And 4B, distant metastasis. This is a tumor and there is a lesion in the liver. So this is 4B. So it's very simple. Robson staging system is very simple and it's being practiced in many units still in North America. And other is TNM staging system is it's a bit difficult to remember, but it's because it's given by the WHO, so it's being used all over the world. So one should know and remember this staging system. So you can check from the book. It's a busy slide. Renal cell carcinoma metastasis. 70% of the cases it metastasizes to the lung, then to the bone, 40%, liver 34%, and local lymph node 22%. Sometimes very rarely to the brain and adrenal. Treatment: localized disease, stage 1, 2, and 3. Robson, stage 1, 2, and 3. One is limited to the kidney, two is IVC and the local lymph nodes. One is limited to the kidney, two is it has come outside the kidney but limited to the Girota's fascia, and three is when it has gone in either to IVC or the local lymph nodes or into the both. So localized disease, when there are no distant metastases. So the treatment is radical nephrectomy, removing kidney, Girota's fascia, ipsilateral adrenals, and local lymph nodes. Nephron sparing surgery, which is also called partial nephrectomy. I'll just talk about nephron sparing surgery in next slide. And sometimes surveillance, just to wait and see. Surveillance is done in very small tumor. If it's less than 3-4 centimeter, and you and the patient is asymptomatic, you would like to go for wait and see. Medically unfit patient, yes, you have to do surveillance. And non-willing patient, sometimes the patient is not willing, then we are left with the only option that to observe the patient. The different approaches: the open technique, open surgery, this is a renal position, and through the lumbar approach, the kidney is approached and the kidney is removed. Then is the laparoscopic, this is the laparoscopic nephrectomy, and later the robotic. So this is a tumor, this is the kidney, and this is the tumor. This is this is the capsule of the tumor. This is exophytic. The tumor is coming outside, extending outside the kidney like a ball. This is the tumor is coming outside the kidney like a ball. Nephron sparing surgery, partial nephrectomy. Indications: tumor in a single kidney, other kidney is either absent or had been removed, and the patient is with only single kidney, you will like to do the nephron sparing. Tumor in single functioning kidney, patient has got two kidneys but somehow or other one kidney is non-functioning, then you would like to do the partial nephrectomy. Bilateral renal tumor, both the kidneys have got renal tumors, then you would like to do the partial nephrectomies in both kidneys. Bilateral renal tumors are around less than 10% of the cases. So what is the prerequisite that you can do the nephron sparing surgery or the partial nephrectomy? Margin of at least 5 millimeter normal tissue. When you do the partial nephrectomy, you have to leave behind, along with the removed tissue of 5 millimeter margin. Yeah, I mean to say is the tumor and the 5 millimeter of the normal tissue, you have to remove it. The tumor should be less than 4 centimeter, and ideally if it is polar, upper or lower pole, then it is easy to remove. Away from the hilum, upper or lower pole. Survival rates comparable to radical nephrectomy. If it is correctly done, the survival rate is around equal to the radical nephrectomy. So this is nephron sparing surgery. This is kidney and this is the tumor, and it has been removed like this. it's removed. This is the tumor, and this is the 5 millimeter normal tissue which I was talking about, that you have to remove 5 millimeter of normal tissue along with the tumor. Then you have to remove stitch. When you remove this tissue, you have to stitch pelvic system and any vessels, and then you have to stitch the renal parenchyma. Partial nephrectomy performed. This is the intraoperative view, and this is when it has been removed. This is the kidney, this is the tumor, this is the normal tissue removed along with the tumor, and this is the specimen removed. Disseminated disease. When there is a tumor has metastasized to either to lung, liver, bone, or brain. So what to do? So surgery, then it's not, surgery is not curative. It may be just palliative. So what to do? Surgery, yes, no, no clear answer, as it's not curative. But if the patient is bleeding, having massive hematuria, you can remove the kidney or the tumor. Radiation in renal cell carcinoma, probably no role. Hormonal therapy, plus minus interferon 6 and few other growth factors are coming up, but it's not definitive. Chemotherapy in some cases, radioimmunotherapy, and biological response modifiers. These are very expensive, and normally patients are not affording. And the other thing is the complete response rate is 10-20%. There is no, significant complete response rate, but partial response rate is 30-35%. So this is the different drugs used. Thank you very much. God bless all of you.